Good evening. It's Dr. John Bennett broadcasting from Miami. Tonight we have another neurology web TV program with Dr. Andrew Wilner. Dr. Wilner is an epilepsy expert and he's a neurologist. He has a regular column for Medscape, and tonight he's going to talk about a paper, opioid use in epileptics. And before Dr. Wilner takes over, let's go through the panel and please introduce yourself. Hello, Roxanne.
Hi, I'm Roxanne Davenport. I'm an epilepsy advocate. I have epilepsy myself, and I want to spread the word, awareness, let everybody know that things need to be done for more research and more money raised.
Okay, welcome, Roxanne. That's your blog, right? Seizure of the Day?
Yes.
Okay.
Without the quotes.
Okay, yeah, that's right. Good evening, Adriana.
Hello, everybody. My name is Adriana Vallejo. I'm from Monterrey, Mexico. I'm a medical doctor working in clinical investigation.
Welcome, Adriana. And Mohammed.
Hello, everyone. My name is Mohammed. I come today from Toronto, and I'm glad to be here today to listen to Dr. Wilner and be with the great panel members.
Yeah, and Mohammed is interviewing for a neurosurgery spot at Boston University. And okay, welcome, Andrew. It's all yours.
Well, thanks very much. It's I guess we have all of North America represented here. That's nice.
There we go.
And so what I was trying to show earlier is just a copy of a publication that came out this month from my group on some research that we did, and I thought I would talk about that. So that's Wilner in Epilepsy and Behavior. And the upshot is that everybody knows now that there's an increase of use of opioids by the North American population, and that this is a big problem. The FDA came out with new regulations just recently, and we noted in a prior paper a couple years ago, we looked at people with epilepsy, and we were trying to figure out where does the money go. You know, it was a paper about costs and utilization. So we looked at hospitalization and ER visits and doctor visits, and of course we looked at their medications. And the number one class of medication, as you might expect, was epilepsy medications. That's what people with epilepsy need to take. So that was no surprise, but what was very surprising was the number 2 class of medication that were taken by people with epilepsy was opioids. And this is from prescription claims. So we know that this is real data. It wasn't by, memory, or I think I took this, or I thought I took this. This is from the actual bills that came in. So for some reason, opioids are the number 2 class of drug taken by people with epilepsy. You say, well, that's strange. Why would that be? And then we thought, well, maybe opioids are the number 2 class of medication taken by everybody. It seems that there's a lot of prescriptions for opioids for people, and maybe epilepsy people aren't any different. So we didn't really have any way of knowing the answer to that with the data that we had, because that data, the cost data and utilization data, was only from a large cohort of people with epilepsy. So we said, why don't we do another study, and let's compare the utilization of opioids of people with epilepsy to matched controls. So we were able to get 10,271 people with epilepsy, their claims data, and we matched them 1 to 2. So we had 20,542 matched controls. So we felt this was a pretty large sample. It's probably the largest sample of any study like this. And we were able to get this sample because I work as a consultant, a medical advisor for a company called Accordant Health Services. And Accordant it's a division of CVS, and it was one of the first disease management programs. So Accordant has tries to manage chronic illnesses along with the physicians who have the patient. So we serve as a resource. So we have patients enrolled in our services all over the country. So our cohort was from a number of different insurance companies that are all over the United States. So it's not necessarily a representative sample of all people with epilepsy, but it was a pretty large and fairly diverse sample. But it was restricted to people who had insurance. So it did not include uninsured people, and it did not include very many Medicare people, because the Medicare people didn't really enroll in the accordant programs because they had Medicare. So it was a younger, actually healthier population, a lot of working people, because that's how they had insurance. Okay, so what we did was we went through all their claims and looked to see who had a prescription for opioids in 2012 and who didn't. And we found that 26% of the people with epilepsy had at least one prescription for opioids during that 12-month period versus 18% of people in the general population. And that was a statistically significant difference. And it's just an observation. And we had no idea why that should be true, but the numbers were fairly convincing. So once we saw that, I'm just trying to pull up a table here on the other side. We thought, well, why should that be? Opioids are not indicated for the treatment of epilepsy, right? They're not indicated for prevention. They're not indicated for treatment. However, people with epilepsy do have more fractures, for example, about double the regular population. They fall, they get hurt during seizures. So maybe they're treated for pain more. That was one theory. So we looked at 16 pain categories that were coded. Joint pain, abdominal pain, headache, limb pain, chest pain, migraine, backache, fracture, fibromyalgia, chronic pain, jaw pain. So we came up with 16 of those and compared the claims for these various categories of pain in the epilepsy population to the control population. And sure enough, the claims for every single one of the pain categories that we looked at were increased in people with epilepsy versus controlled. Statistically significant p-value 0.001 for every single one. So for whatever reason, people with epilepsy are being treated for more pain conditions than people who don't have epilepsy. So that was our second very interesting finding. So that's pretty much what we found. We really don't know why this should be, and that's one of the things I'd like to discuss. You know, one of the theories would be, if you have epilepsy, maybe we know that you will present yourself to your doctor or the emergency room or the hospital more than someone who doesn't. So you're interacting more often, right? So there's an interaction bias. So it just may be that you're interacting more often with the healthcare system, and that makes you more likely to get an opioid prescription and more likely to get a diagnosis of fibromyalgia or back pain or something like that. It may be, we know that people with mental health issues are more likely to use opioids. And we know that many people with epilepsy have anxiety and depression. Some are treated, some are untreated. And it may be that that's one of the reasons that comorbidity predisposes to self-treatment and use of pain medications. Another theory was that people with epilepsy are more sensitive to pain. They may have a different pain threshold. It may be that they require opioid treatment more than the general population, but we don't have any evidence of that. So one moral of the story is that if you're a physician taking care of people with epilepsy, that you should pay attention that if you are prescribing opioids, you know, these are potentially dangerous drugs and there's misuse and addiction and diversion and lots of problems with opioids. I'm licensed in Massachusetts, among other states, and we have to do 3 hours of opioid training, CME, every year. It's now part of licensing. So it's recognized that this is a big issue. But why this should be, we really don't know. It's an observational study, how to delve a little deeper into this. What do you think about this, Roxanne? Does this jive with your experience?
I'm the exact opposite. I have migraines, but I take the sumatriptan and then the Tylenol with it. But I catch mine in time. I don't have to take any codeine, anything like that. So that's odd. That doesn't describe me.
Right.
You know, Roxanne, since you deal with a lot of epileptics, what are how about with other epileptics?
Well, some friends, they have fibromyalgia.
Okay.
And so they deal with that, and they say they have to take pain medicine for that. So thank goodness. Maybe I guess maybe they don't get out as often. I'm lucky because I'm active, and it depends, I guess, which epilepsy, what's your diagnosed type of epilepsy you have, as to why you need it. So did you see what types, or break it down any further as to what kind of seizures they had?
Because of the claims data, we were not able to do that. If you look at claims, you know, whether it's partial seizures or partial complex seizures or partial seizures with secondary generalization or primary generalized seizures, either it's not coded or those codes are really not reliable. You know, they're trying to fix this with ICD-10, you know, to get everything more precise. But all we could say was epilepsy or not. We really weren't able to say which kind of epilepsy. I don't know if it would make a difference or not, but if we could get a hold of that data, right, it may be intractable epilepsy, for example, you know, people who are in the hospital, in the emergency room all the time, breaking bones, maybe they're the high users. We did break it down a number of different ways. Let's see, I think I have some more. We tried to figure out, you know, some other correlations, but, you know, men versus women, things like that. We really were not able to find a lot that was helpful. We did find, of course, that migraine was in 8% of our population, while the control is only 2%. Here we go. So among women, the percentage using analgesic opioids was 30%. That means 1 out of every 3 people with epilepsy, every 3 women, is taking an opioid. And for men, it was 20%, so 1 out of every 4. Now you have to balance this with our observation, and in the general population, it's 1 out of every 6. So these numbers are not that different, but they were statistically different. And among women, the percentage with a pain condition, it would include migraine, was more than half, 56%. Controls 42%. For men, 45% with epilepsy had some pain condition, comorbidity, and controls 35%.
I can add another factor to migraines, the cause of migraines.
Okay.
Cycles, menstrual cycles.
Sure.
Might be why there's more women with migraines, other than epilepsy.
That's right. It's a known comorbidity. So there's a gentleman there with a sport coat. I didn't get his introduction.
I haven't met. This is a new member, Slaven Golkovic. He's a medical student from Croatia. Say hello to Dr. Wilner.
Hello. Hello, very nice to meet you. My name is Slaven, as Dr. Bennett introduced me, and I'm here in Croatia. It's actually 3 a.m., but I wanted to see you on Hangout, and thank you for allowing me to participate.
We're bringing it to Europe too, Andrew.
Yeah, that's great. Well, thank you for participating.
Thank you.
That's terrific.
I have a question, Andrew. Is epilepsy pretty genetic? Is a heavy genetic disposition?
Well, they look at this constantly, and about half are unknown, right?
Okay.
So the etiology unknown.
Yeah.
So we presume that a lot of those unknowns is some genetic cause. 4% or so are due to head injury, and then you've got, in the older population, strokes and tumors. But there's really, the pure genetic ones is not really the majority.
Well, because I was thinking,
There's so many causes.
in medical school, I remember being taught that if you find one genetic problem, usually there's others, or there can be others. I was wondering maybe with epileptics, if there's a heavy disposition, and you believe that alcoholism and drug abuse is a disease and genetic, that may play some role. What do you think about that?
Well, we do believe there is a co-genetic with migraine for sure.
Okay.
Migraine is clearly genetic, and people with migraine, people with epilepsy are more likely to have migraine. So I think somehow those genes must go together. They must be near each other on the chromosome and tend to travel together, would be my thought. But in terms of all these other comorbidities, that's a lot more mysterious.
Right.
And, pain, for example, or fibromyalgia, or joint pain, these are kind of random. It's kind of hard to figure out what that has to do with epilepsy.
Mm-hmm.
Mm-hmm.
But we really don't know.
Has a substance abuse problem alone been studied in epileptics, if it's higher than the normal population, or does your study address that?
Well, in fact, that was one of the things that I wanted to address in our next one, is whether if there's more opioids being used, are there more overdoses, for example?
Right.
Is that excessive opioid use leading to excessive complications?
Mm-hmm.
I don't know the answer to that. Substance abuse is very hard to study because the data, patients don't often admit it, so it's very hard to say, oh yeah, do you have substance abuse? Yes, right? A lot of people say no.
Right.
If it comes down to that, you might have helped SUDEP. If they take too many opioids along, you might have figured out what causes SUDEP.
Well, I think if mothers are taking it, and people are taking it, overdose, respiratory depression, yeah, I think that's something that has never been discussed, and it might be worth checking. A drug screen ought to be sort of, maybe that's something that should be done more routinely. Yeah, so I think it's an issue. I think it reflects the general opioid use in our country, which has grown. Mm-hmm. But it seems to be even more so in people with epilepsy. So I think it's something people need to be aware of, and doctors should ask about, when they're seeing patients. People get, all kinds of stuff, after they have their teeth pulled, or, leaving the emergency room. And that's legitimate. But there seems to be an agreement that there is an excessive use of opioids in the country.
Mm-hmm. Well, that's certainly important for physicians to note that when they treat epileptics. Now, this is maybe kind of a naive question. Do most patients with epilepsy, are they treated by their general practitioners, or do they see a neurologist? That's a question for both, I guess, you and Roxanne.
Yeah, so that was a surprise to me. I'm an epileptologist, and I just assumed that epilepsy patients go to epilepsy doctors. But in fact, if you look at all epilepsy patients in the country, most are treated by their family doctor or their internist. And I bet in Croatia, it's probably a rare epilepsy patient that ever gets to see a specialist. I don't know about in Canada also. I think the specialists are few and far between. Is that right?
True, Mohammed? Is that true, Mohammed?
Mainly here they see the primary care physician. They would consult with a neurologist, but mainly they would be seeing their primary care physician.
How about in Croatia?
Right, if they're lucky,
Yes.
they might get to see a neurologist like once in their life, and then they get referred back.
That's right.
Yes. Same in Mexico. Most of them see the neurologist once a year, maybe, and then the family doctor is the ones that see them every month.
Okay.
Yes, it
How
is.
about Croatia, Slaven?
It is the same here. They are usually first time seen by a specialist, and then they are treated by a general practice physician. So
Okay.
it's often not enough to keep the process through the time. You know, so they often have regular seizures, and this is inadequate, I think.
Mm-hmm.
So, Dr. Wilner, that brings a question that I had when I read the paper. You mentioned in one of the theories that those patients with epilepsy, it's likely they've been seeing like a healthcare provider who might been like diagnosing different problems and giving them the opioids for that problem. Have you considered looking into control where would be patients with chronic disease where they have to go see physicians on a regular basis and compare the opioid use? Have you considered such possibility?
Oh, that's interesting. Like looking at a S group or rheumatoid arthritis. Well, that's tough because that's a pain issue. You know, or an asthma group. Asthma is sometimes used because you know they don't have pain, but they have a lot of doctor visits. Yeah, I think that's a great idea. That would help determine if it's a bias due to the frequent visits. Yeah, that's interesting. It could be done.
Mm-hmm.
Mm-hmm.
The next study. Has this paper been published yet, Dr. Wilner?
Yes, it's online now.
Okay.
It's just published this month on epilepsy and behavior.
Okay.
And if you'd like to look at the other papers, if you just go to PubMed,
Mm-hmm.
search Wilner and epilepsy, they pop right up. This is the fourth one in our series of trying to do some, you know, epidemiologic cost and utilization studies. The
Mm-hmm.
opioid thing, as I said earlier, was kind of a surprise.
Mm-hmm.
It wasn't, you know, something that we knew was a problem. It just kind of popped out of the data,
Mm-hmm.
and so we decided to look into it further.
So you someone mentioned it to you, or you just kind of noticed it in some patients, and you said, I'm going to do a paper on that?
Oh, yeah. Well, no, when we did our drug study, we found that opioids were the #2 drug. You know,
Right.
I figured it would be antibiotics, you know, or hypertensive medicines or diabetes medicines, and opioids is #2. It's like, wow, what's going on there?
Mm-hmm.
So that's why we decided to look at it.
Are you going to write a column about this in Medscape?
Yeah, most likely. I'll try and get somebody to interview me. Barring that, I might just talk about it myself.
Okay. Well, I'll be glad to do it. Or if you want to get a neurologist, well, we could set it up.
How about somebody with epilepsy?
Yeah.
But I have another question. Does it matter about which medicine you take, which name? Like the ones that say, you know, can cause depression, can, you know, cause you to commit suicide or something like that, as to which one would want to make you take a opioid more? Because of the side effects.
We did not examine that. We didn't compare the medicines that the patients were on. That would be something else we could do. In other words, were they on this medicine or that medicine, or how many medicines? That might be another thing. It might be that people on 3 medicines were more likely to use an opioid. That would be something else that could be looked at. It actually took quite a lot of work to get as deep into this as we actually did. But now that it's done, it's easy. You know, the whole idea is now we can get a little bit deeper.
And
That's
definitely the blood levels on some of those, because I have to check my lamictal level every 6 weeks or every 6 months. So that's definitely another thing to check.
Well, I'll give you a homework assignment, Roxanne. Next time you have one of your advocacy meetings with a room full of epilepsy patients, ask how many are taking any narcotics or pain medicines, like oxycodone or tramadol or hydrocodone or any of those. It'd be very interesting to see who raises their hand.
Okay.
According to our study, you should get at least a quarter of the room ought to be raising their hand. So that'll be interesting to see.
All right.
Well, hello. I got something to show the audience here. You probably recognize that book, Andrew.
Yeah, thanks, John. That's right. That's my book of blogs that we talked about earlier. It covers a lot of issues, a lot of controversial issues in epilepsy. There's 100 different essays in that book that all appeared on Medscape, and I updated all of them for the book, with what happened. And the people asked me about the title. That refers to Gabrielle Giffords when she was shot in the head.
Mm-hmm.
The congresswoman actually from Arizona. And I was just stunned by the reporting at that time where they just emphasized, she's just getting the greatest care. She's in the hospital in 30 minutes. They're flying in world-famous neurosurgeons. She's getting excellent care, and she's doing great. Everyone says she's a great patient, and even during her rehab, she's doing great. She's a terrific patient, which was all true. The problem is once you're shot in the head, it really doesn't matter what you do. And we don't have treatments for that. And they really underemphasized the finality. I predicted, and I wrote this just a few days after. I said, this woman is going to lose her job. She's a brilliant congresswoman, and she's not going to be able to continue that job. And she resigned eventually from the Congress. And her life was totally devastated. So the brain, I was just emphasizing, of how delicate the brain is. And this goes along with what we were talking about earlier, also with the, post-concussive syndrome and multiple concussions. When you go to the operating room and you see the brain there, and you touch it with your finger, it's just like Jell-O. You can put your neurosurgeon, is neurosurgeon there? One of you guys neurosurgeon, right? You can just put your finger right through there if you're not careful. You got to really be paying attention all the time.
Right.
The brain is not made to be banging into things and to be getting, bullet fragments and all of that. And I felt that really needed to be pointed out. So that's what generated that essay, and the rest of the book kind of followed with a lot of different topics.
Andrew, when you have time sometime in the future, I would love to have a hangout with you about what you mentioned about how you were pointing out that repetitive trauma to the head is not a good thing, which actually I was surprised you mentioned that before the show, is that, of course, there's a lot of press now because of the attention paid, but in the early days, you must have thought you were anti-sport and anti-American, and how dare you say that?
Yeah, so I'm kind of proud of myself. I like to stick my neck out on these topics, and then you just go with it and see if you were right a few years later.
Well, the class action suit proved that you were right. The owners settled. You saw the amount, right? Did you guys see the amount? It was like in the billions of dollars to dismiss the case of the players' union against the NFL because they had, I guess, scientific proof, and they had doctors willing to go to bat for that fact that repetitive trauma can cause encephalopathy.
Right, so there's that movie, which I haven't seen yet, but I understand it's pretty accurate. It's worth seeing. Yeah, so it's nice to know you can get one right on occasion.
Well, I've tried to get a hold of I guess there was a pathologist in Boston, or a female, and I think they depict her in the movie too, as well as another pathologist that led the drive and that fought against the NFL because the NFL was trying to intimidate them. And there was this woman going into a room full of men. I mean, probably the testosterone level in that room was pretty high when she went in to explain to them that then what you're doing may cause brain damage. I mean, that must have been a tough crowd to convince.
Yeah, I'd love to speak on that, John.
Yeah, that would be an excellent topic. And
we'll get some neurosurgeons too, because they deal with it all the time.
Yes, yes. I think that would be an excellent topic. So, well, Andrew, I think you've done what I call hangout publishing, which means that someone like you that may write an interesting paper, the author comes on and basically goes to the paper. And I've talked to John Adler, a neurosurgeon that has a service called Curious.com. Are you familiar with that, Curious.com?
I don't know that one.
Yeah, it's an online publishing that's designed to kind of shorten the time of publication to try to make it easier. I'm trying to get him to do that. When you submit your article, you're the writer, the main authors are interviewed on the internet and with the relevant subject discussing it. I call it hangout publishing.
I think that's a great idea. In fact, I'm preparing. Epilepsy and Behavior is now offering an option to do audio slides that will accompany your paper, so that you can kind of talk through your findings. And I haven't done it yet, but it's on my list of things to do for this paper. Mm-hmm. I think the idea is, to give the authors an opportunity to sort of explain it, because the papers get kind of technical, and I think it's nice to be able to have an opportunity to discuss it.
Yes. Well, I've been doing hangouts with people that make medical devices, and it's very interesting. You meet the people behind the science and get to talk to them, and they get to tell you how their medical device evolved, why they started it, and where they think it's going to go. It kind of puts a different angles than just reading about it. It puts the person behind the letters, so to speak.
Oh yeah. Well, John, I want to thank you for this opportunity to talk about the research that I did with my colleagues who did an awful lot of the work. Yes. Dr. Kruger and Dr. Shama and Amy Thompson. So I'd like to give them credit as well, and hopefully we'll have another one in a year or so.
Okay. Well, just let us know if you ever want to do a hangout. We'd love to have you, and thank you very much, Andrew, and thanks to all the panel.
Thanks everybody. It was a pleasure meeting all of you. I hope to see you at some meetings and in future hangouts.
Okay, Andrew, I'll send you the link.
Great. Thank you.
Thank you very much.
Good night.
Good night.
Thank you, Dr. Andrew. Good night.
Okay, stop broadcast. Boom.